Hi, everyone. I hope you can see us. We're just going to wait for a few minutes so that a few more people can join, and then we'll get started. Just bear with us for a minute. Okay, why don't we get started? So welcome everyone to the second webinar of the Intro to Research series. Thanks for joining us. Today we have Pav, who's going to be doing the talk. So I'll hand over to him now and hope you guys enjoy.
Thanks, guys. Thanks for inviting me to present, Nilesh. So my name's Dr. Pawandeep Sarai. I'm a consultant anaesthetist at St Mary's Hospital in Paddington in London, and also a clinical senior lecturer at Imperial. And what I'm going to be talking about is how I went about doing my PhD and what that meant for my life and what it's meant for my life now. So it's basically my experience. This isn't in any way an informal guide to how to do a PhD. It's just my experience of it. I'm going to tell you a little bit about who I am and what I do, how I got here in terms of how I got to do my PhD and then my job. And I can give you an idea of the sort of standard and non-standard ways that you can get into doing a PhD, and then some of the pros and cons that I think there are to your life as a result of doing a PhD or an MD. So who am I? So I'm a consultant anaesthetist. So I work at a big vascular trauma centre, and I would say one of the reasons I ended up here and got this job is so one of the reasons I got this job was because of the PhD that I did. Now, a lot of people do PhDs that are completely unrelated to their future careers, and there's absolutely nothing wrong with that. The PhD is a process of learning research and research methodologies and lots of transferable skills. So the actual topic doesn't really matter, but when it does, it can really be beneficial to your future career. My other job is that I am an applied physiologist, or a neurophysiologist more specifically. So I spend about 60% of my time doing clinical work and about 40% doing research. Very little bit about my background. I graduated in 2007. I did a BSc in pharmacology, which was offered to me at my university. I've never taken any particular interest in pharmacology ever again, so I don't necessarily think doing the BSc topic itself again affects what you do in later life. But it definitely gave me the interest that I had in doing research, because I had a really exciting project with a really exciting lab group that I worked with. My foundation training was fairly standard. I did I think it was 4 months. It might have actually been 6. I can't remember. It was so long ago, but it was it had an academic component to it. And lots of people ask me whether being an ACF is essential to getting into academia later in life. And I would say it definitely isn't. It can help. It can give you some really useful contacts. It can give you an idea of what the research life might be like. But I know plenty of colleagues who are doing PhDs at the moment, or have done them in the past, who have never done any real formal academic sort of training or academic work in the past. I did anaesthetic training for a really long time. The reason being that I took 4 years to do a PhD, and I'll come on to the duration of PhDs as part of my talk. And I also did an extra year doing some extra anaesthetic stuff specific to what I wanted to do. My PhD topic itself was actually clinical medicine research. Now, this is quite an interesting umbrella term that a lot of universities use. And it basically really amounts to doing translatable research. It isn't really a specific research field, but I did a project that involved applied physiology, specifically neurophysiology, but it could encompass lots of different aspects of science and basic science. But the focus is really that you're trying to improve an area of medicine by doing the research. So I'm just going to hand you over to Nilesh again, just to go over some Mentimeter questions.
Yeah, so we'll quickly do a few questions before the webinar and then after again, just to see how much you guys have taken away from this. So let me just share that. And if you could try and join using that code up there, that would be perfect. I'll give it a second for everyone to join in. So yeah, I think it just came up. So if you could join that, that would be great. I believe it's saying the quiz is not open for some people. Let me just have a look at that. Give me 2 seconds, guys. Okay, let's try that again. Okay, let me just share my screen again. Okay, so there's a few people join, and hopefully you can see. So let's begin. Perfect, good. So it seems like you guys already know a little bit. So let's do the next one. Perfect, and let's begin. Perfect, good work. All right, so I'll stop sharing now and back to Pav.
Cool. Thanks, Anish. So what do I actually do? And the reason I'm talking about my job is not because I want to sort of gloat about it or anything, although I do have quite
You
a cool
might need
job.
to share your screen again. Sorry.
Oh, sorry. 1 second. Is that working?
Yep, perfect.
Perfect. Yeah, it's not because I want to particularly gloat about what I do, although what I do is pretty cool. It's more that it can give you an idea of what your PhD might mean for your sort of future career. So like I said, I do vascular anesthesia in particular, as well as trauma, just because I work in a trauma center, you kind of have to do it. But we do some very big aortic cases, and those aortic cases are not really done very many places, and as a result, there aren't that many jobs in it. My clinical question as part of my PhD was very much related to this patient cohort, and I think without my PhD, I would not have had the CV or the background really to claim to be in any way an expert and able to anesthetize these patients. So I really felt one of the ways that I could get a job in an area that I was interested in was by doing a PhD. That's not true for everyone, and it's not true for every specialty in medicine, but I think a PhD is always going to be valuable, and sometimes if it's very much related to what you're interested in as a future career, it really can help you get the job that you want. The other thing that I do, sorry, slightly grainy picture, is like I said, I do neurophysiology, and one of those things that I do as part of my job is that I do research on spinal cord pathways, and we are we take in students as well as part of our, because we work at Imperial College, we take anesthesia and surgical students in their BScs. And again, the only reason I have this this clinical lectureship is again because of the PhD that I did. So it allowed me to have the job that I really wanted, and I've shaped it in the way that I wanted as a result of this. So how did I get here, which is probably more pertinent to this topic, is so I took a slightly non-standard route into getting into a PhD. So like I said, I did a BSc project, and I very much enjoyed the lab work. I got reasonable success out of it. We got a abstract and a poster presentation. Nothing particularly wild. There was no Nature paper. There was no, there's no New England Journal sort of RCT. There was just a very standard basic science project, but found it very interesting. Did the ACF. It was okay. Didn't really get much out of it. Probably because I didn't put much into it. It was fairly sort of routine for me. But I did little projects along the way. I did a couple of little abstracts with one or two of my jobs along the way. Did a QI project and pushed it as far as it could go and got it sort of published in a reasonable journal. And I kind of ticked along. There was no real particular desire to do anything formal, but I kind of thought that maybe one day I would, but maybe I'd missed the boat. And then I was sat doing a neurology case, a neurosurgical case, and I just finished a vascular placement, and I came up with an interesting idea based on what I was seeing. And I asked the bloke that was there about my idea, and he thought it was fairly interesting. And he passed me on to somebody at Imperial College and said, "Why don't you speak to this guy? He's a friend of mine. He might have a better idea." So I went and spoke to him, and he thought the idea was really interesting, but he didn't feel that he was in the best position to fully supervise me in any way. With me being a clinician and him being a basic scientist, he felt maybe some clinicians should be involved. So he contacted his mates, who happened to be a surgeon and an anaesthetist that were working in the Faculty of Medicine. And after lots of various meetings and lots of discussions of whether it was even possible to do this, we thought, actually, this is quite an interesting idea. So it all came from a simple idea that I had, and I then pursued it myself. So it's somewhat of a prospective way of doing it. So there was no funding in place. There was no ethics in place. It was literally an idea. The only way I was going to get this off the ground was there was literally no way I could do this as part of my clinical job. So I had to come out of training in order to do that. So the first thing that I did was that I took an OOP-E, and I convinced my my training program directors for this anaesthetic school that I was in that I really wanted to do this. and they kind of bought it and thought, well, it's only a year. Why don't you go for it? So I took an UP, and an UP doesn't count towards your training. It is literally a pause for a year. And in that time, I wrote the ethics, I wrote the protocol, and I sourced some funding. It took about 9 months for me to do that. Now, during this time, I didn't have an income because I'd left training. So I managed to speak to St Mary's Hospital where I was hoping to do this research. And I just met this anaesthetist and surgeon who said, actually, we have a gap on the rota. Why don't you come along and do some of the on-calls there? So that's how I managed to get some income so that I could afford to eat and live in my house. So once that got going, I then applied for an OOP-R, and I think it might have changed now, but when I did it, you could only do it for 3 years. So I have a 3-year window within which to do this PhD. Unfortunately, towards the end of it, COVID happened, so I wasn't able to actually finish everything that I wanted. So I ended up submitting about a year or so after I'd actually gone back into training. Now, universities are actually really good about how you submit your PhD. There's no, although you have these milestones that are usually at 1 year, or usually at 6 months, somewhere between a year and 2 years, and then your submission of thesis and viva, actually there's lots of ways you can extend it if you need to. They've invested as much time and money into you as maybe you have as well. So it's in everyone's interest for you to complete your PhD, and they will extend it. So even though I'd gone back into training, they allowed me to go into something called writing mode, where essentially I paid a token amount of money, or my funding paid a token amount of money, just so that I could have access to college emails, college library services, and all the references, etc., so that I could then submit my PhD. I touched upon it already, but I had a clinical commitment throughout my PhD. Now, pretty much every single person that I know has this as a clinician. Usually you're used to an income of, depending on your grade, between 40 and 70 odd thousand. When you do a PhD, depending on how your funding works, this can drop anywhere between 30 and 40,000. So you suddenly have this disparity between what you used to earn and therefore what your lifestyle has kind of worked around to having a lot less. So pretty much everyone I know who's a clinician doing a PhD will do clinical work. I continue to be on call at a busy trauma center. Now, that wasn't the easiest way to earn money, but it had a number of benefits for me. One, the patients I was recruiting were based at this hospital. So if I was going to see any of these patients and try and recruit them, they would be coming through that hospital. I also, in my head, wanted to have a job at St Mary's. I kind of made that decision already. And so what I decided was that by working, sorry for the distraction. One of my children is trying to get into the room. Anyway, sorry. I decided that I wanted to work at St Mary's. So one of the ways I could do that was by being on the road, so being around and being useful in the department. A simpler way would have been to join a RMO type service and go to a private hospital. Most of the people that I know do something like that. They do a few hours during the day. It's usually a 24-hour shift. They do a few hours during the day. Almost all of them will sleep overnight, and they often get some reading and writing done as well as part of their PhD. So it works quite well for them. A couple of my friends do clinics once or twice a week, and just one second. Sorry, problem with having kids and bedtimes. So that's another common way that people do it, is they do clinics, and it's sort of specialty dependent. A lot of surgeons will do occasional on calls, they'll do clinics, and my gastroenterology friend does clinics, for example. The other benefit of working with the affiliated hospital with the university is that often staff can get reduced fees as well. So it's usually half the cost. So if your annual fee for your PhD is £6,000, it'll be half of that will be 3,000. which you can then use the additional money from your funding if you've got a grant to use for consumables or your salary. If you're self-funding, which I'll come to later, then you only have to pay £3,000 instead of a full amount. So how is it possible for you to sort of get into this route? Because mine was a slightly non-standard route. So like I said, I set the project up and funding was prospective. Most PhDs are not like that. Most of the PhDs and MDs are already set up and pretty much ready to go. They're usually continuation of projects that have already been going on for many years, and usually it's a slight tweak to the protocol and they'll get another PhD out of it. I'm not trying to sound disparaging, but that's what a lot of PhDs are like. And they're very successful, and that allows, you know, a constant turnaround of projects and PhD students. It's a good way to constantly have papers. The more papers you get, the easier it is for you to get funding. So it's actually a very good model that a lot of clinical departments that are doing PhDs will use. The ethics is in place, the funding's in place. It's very straightforward. It can make them quite competitive because they are very successful. But you know, if you're keen and willing and have all the right stuff, then you know, they are a good thing to do. There is a slight difference between a PhD and an MD. On the whole, from what I understand from having spoken to colleagues, there's very little difference in terms of your likely clinical trajectory. If you're doing a PhD for the sake of getting a good clinical job, it probably doesn't matter whether you do a PhD or an MD. I use surgeons as a common example, but surgeons often almost seems like a requirement that they have to have a PhD, whether they want to go into academia or not. They all seem to have some form of higher education. For them, it doesn't matter whether they do a PhD or MD. It kind of pretty much gives them the same points, the same weight, gives them the same contacts, and hopefully they'll get the job that they want. If you're looking for a PhD as a way into doing academic work, then a PhD probably is more valuable. But again, depending on what your PhD project is and what you get out of it, an MD could be more valuable. You know, if your output from the MD is great, then to get an academic job in the future, that output would probably outweigh whether you've got a PhD or an MD after your name. So it's not clear cut which is better, but if you're looking for a good clinical job, the easier and cheaper way to do it is to do an MD. It's a shorter time span, usually 2 years. The project at the end, or the thesis at the end, is smaller as well. Not exclusively, but almost always. Sorry, not almost always. It's more likely that the MD is less work. The other way to do it is self-funding PhD. So I didn't realize these existed, but there are people that I'm currently working with who are paying for a PhD themselves. So these are really good for projects that are theoretical, so they don't have consumables, they don't need a lab space. They're really good for projects that maybe a lab has already bought all the equipment and all you need to do is use a few consumables, if any. And the only thing you're paying for is the university fees in order to use a lab space and get the PhD at the end. A self-funded PhD usually seems to be done by people who have lots of money, so they don't mind not having a job because it's hard work self-funding a PhD, or it's done by people who maybe have a fairly established career and can take that time out. So the people I'm thinking of are a consultant surgeon who decided he wanted to do a PhD much later in his career, and a senior physiotherapist who's doing one as well. And their projects are all entirely self-funded. So what are the cons of doing a PhD? So what I think might be a con might be a pro to other people, but this is just my feelings and my reflections. There is a lot of kit and a lot of techniques that you have never seen before. So this was my lab, my original lab when I first walked in. I'm used to putting cannulas in and sticking tubes down people's throats. This is not something in any way I was comfortable with. And it was a very, very steep learning curve learning how to use these. I touched on it earlier, but a clinical medicine research PhD does not require you to have a relevant BSc or MSc in any particular field. That's slightly different from somebody who's, say, doing a pure neurophysiology, like a pure neuroscience PhD. You would be expected to have a master's. You'd be expected to have done an MRes, for example. Clinical medicine research doesn't work like that. The idea is that you're translating stuff into a clinical space. Therefore, your clinical knowledge is where the value is, not whether you have any science background. However, you do need to know some science, and you need to learn it quickly. And that was in seriously hard work. I'm used to seeing ECGs, and instead I'm seeing this kind of stuff, and I have really very little idea what's going on. And you have to learn quickly. You're generating data that you don't really understand. You have to learn how to use things like Prism and R and all this kind of stuff, which you don't know anything about really, and you haven't used it in any meaningful way during clinical work. So there's as well as a steep learning curve is a full-on imposter syndrome, which it's hard to shake when you're surrounded by scientists. The other thing to bear in mind is the sort of personal financial. I've already touched upon it already, but doing on calls while trying to do a PhD is hard work. Being an RMO for 24 hours and then trying to go to the lab is hard work. It takes up a lot of time. It's exhausting, and and often I was spending a night shift at Mary's, and then I had a patient the next day for our research project, so I was frequently doing 24 hours, 30 hours awake. It's just how it had to be. I mean, there were days where it was great and I didn't have anything to do, but there are times where you're exceptionally busy. And like I said, the funding is ultimately limited. So, the reason I've got this picture here is to basically, it didn't really matter whether there was a pandemic or not. The funding had a finite time, and your OOP-R has a finite time, because you're expected to come back to clinical training at a certain time. They've planned your next rotations based on a certain date, and they can't deny that hospital a trainee when they're expecting them because there's been a pandemic. So I lost a certain amount of time, and there was no way I could extend that. The funders were fairly okay, but ultimately, if I'm not physically in the lab because my TPD has told me to go back to training, the funders aren't going to give me the money because I'm not there. So it's a bit of a stress, and it was quite stressful towards the end. I couldn't find a picture of me sleeping because obviously I'd be sleeping, so I can't take a picture of myself, but it's exhausting. I was frequently passing out on the sofa, and it's knackering. You're snatching any moment that you can to try and write up your thesis. Wherever you've got a moment, you've got a busy life, you're trying to do lots of different things. Any moment you can, you're snatching up 5 minutes, 20 minutes to try and write up your thesis. It's hard prioritizing everything that you need to do. And at the end of it, you're producing a massive, massive document. It's hard work. It takes ages. There's no denying writing 266 words isn't hard work. As organized as you are, it's a big amount of work, and it requires a lot of dedication. And you can't go into it sort of lightly thinking it's going to be easy. It's not. However, I think the pros definitely outweigh the cons. Otherwise, I would have dropped out. It is really interesting what you do. I don't know anyone of my contemporaries who didn't enjoy their time. There might be moments where they felt really, really upset and really tired and very exhausted, but on the whole, they all really enjoyed it and found it interesting. You get to go to really cool places. We went to conferences all over America and all over Europe. You get to present your work at lots of different conferences to lots of interested people, and it's your work that you can be really proud of. They're interested. You make collaborations with people all over the world, and you really feel part of a big community producing really useful science. And it's yours. It's got your name on it. Ultimately, this is just to show that I got the job that I wanted. I basically got my clinical job as a result of the PhD in the hospital that I wanted, and I got my academic job where I've got my own established department with a colleague, a couple of colleagues. Where we're probably we're one of only 4 anaesthetists in the country that have a physiology background effectively, so we can create a department. There's no way that would have happened otherwise. And I've got a perfect split. I'm also in a very privileged position where I'm outside of the funding cycle, where part of my clinical job, I'm given 40% of my time paid for out of my clinical contract to do research. So I don't have to have funding in order to do it. I get funding in order to support students, in order to buy equipment, in order to do other things. But I'm outside of a funding cycle. And again, that only happened as a result of doing this PhD. And I have an amazing work-life balance. There's a lot of hard work at the beginning, but I now get to spend time with my family and have a really good time. And the PhD, the research days are flexible. If I need to be off because I've got a sick child, it's not that big a deal. I can just move the research around, and I think I have a really good work-life balance now compared to before. So I'm just going to hand you over to Nilesh, who's going to ask you some more Mentimeter questions.
I'm like the bad guy now, asking all the questions. We'll have a few questions now to sort of see the learning. So let me just share that now. We hope this works the first time around. So same website, new code. Please join up as fast as you guys can. There we go. People are joining. We'll give it a couple more minutes for everyone to get in. Okay, let's get started. Perfect. Good work, everyone. All right, moving on. Excellent. Okay. And last question for the day. Perfect. Yeah, excellent. So those are the questions for today, and I'll hand over back to Pav. If you could just share your screen again, and then if people have questions, please do put them in the chat because we can go through them now.
Cool. Thanks, Nilesh. Final thoughts. Like I said, it's really hard work and it's a lot of work, and you will definitely have days where you want to say, I don't want to do this anymore. I want to quit. But don't. It is very, very rewarding, and it's exceptionally interesting. You get to use a part of your brain that you just do not use in clinical medicine. Lots of doors can open up to you. You can take it wherever you want it to, and no one's going to look negatively on your higher education. And good luck. Hope you all get what you want.
Okay,
So this is a QR code for some feedback. and this is the QR code for the next talk, I believe.
Yeah, I would recommend doing the feedback form because that's how you get your certificate. And please do join the next chat where we'll elaborate a little bit on what Pav's already touched on some of the pros and cons of actually being in that research environment and doing research. And if you have any questions, put them down in the chat. Don't be shy. If you're thinking it, someone else is probably thinking it too. So we have a bit of time now to answer those questions. So I'll read the questions out loud to you, Pav. Does that work?
Yeah, sounds good.
So someone's asked, when do you think would be the best time to do a PhD?
I think I was going to actually say this in my talk. Apologies. So I did mine at ST5. I came out rather at ST5, and that was the right time for me. I can tell you why I did it then. I'd done all my exams. I had an established career as such. I mean, I was fairly well into my training, so I wasn't learning. It was all starting to become fairly routine. I was married, I had kids, I had a house. I'd kind of done everything I needed to. That felt like the right time for me. Others would say that doing it earlier is better because, while you do a PhD, you might de-skill. So do it early, get it out of the way, and then it can shape your training in the future. Perfectly reasonable. I think you kind of have to decide when it's best for you. The natural points are usually at the end of foundation, but I think you might find it hard to be competitive at the end of foundation unless maybe you're a postgraduate and you've done lots of other things in the past. ST3 is usually a natural point, or sometimes it's ST4 for certain training programs where you have a transition from SHO to Reg. And then for me, like I said, it was ST5. You kind of have to decide what's best for you, really. I think I did it the right way because it worked out, but maybe it might have been different if I was doing it as an ST3.
So there's quite a few more questions coming. Thanks, Pav. So there's another one. Can you take a break between core and specialty training to do a PhD without taking an OOP-R?
Yeah, so if you simply don't apply for a training program, you don't have anything to go into. So finish your foundation and then arrange to do a PhD. That's the way to do it. I don't think you could. I don't think any TPD would allow you to take a training program, take a training place, and then get time out straight away. They would expect you to have done some of your training first.
Okay, so next question. Does this apply to an MSc as well? I'm a GP trainee and wondering if there's usually a support for trainees who want to go into a master's or a PhD.
MSCs are similar to PhDs, I believe. I think you'd probably be hard pushed to. You'd probably have to join an established degree program as opposed to a PhD, which is more of a standalone research project. It's not a degree in the same way that a master's is. So if you're thinking of doing a master's, you would apply to the university to do a degree. A PhD is offered by different researchers and laboratories who offer a project that awards you a PhD at the end of it. So they're slightly different. It's sort of different pathways, I think.
Yeah, perfect. And the next one, what are the 1-year options in research during F3? Example, masters, etc. What's good to improve your portfolio?
So there's lots of things. I think you have to be realistic about what you can achieve in a year. If you're looking to bolster your research portfolio, you probably won't get a huge amount done unless there's a project that requires maybe a research assistant, a research associate to help out. Things that are quite good to do are PG certs in education and things like that are quite useful. Quite a number of people have done them. Again, you have to kind of maybe commit to wanting to be more of an educator or a teacher than a researcher. I think other things I know people have done is that they've gone to different laboratories and asked people who are doing PhDs if they have any, or offering PhDs if they have any projects that they could help with. So we had a number of students that came to us between degrees who wanted to do a summer project, and we had short projects that they could do, which actually fed one or two of them fed into my PhD project overall. You just need to approach somebody that you know, or you know who's doing a PhD, to see if there's anything that they can offer you. And I think those are probably the ones I can think of at the moment. I'm sure there might be more, but that's the ones I can think of.
Great. And sorry, I missed a question before, so I'm just going to go back to it. So there's one which says, I'm an IMG from Canada looking to do my MD in the UK. I don't have an incredible amount of research experience, no papers or publications. How can I get research experience which I can use to improve my CV, get into training programs, and publish papers?
So I think if you went to certain laboratories that you might be interested in, ask them if they had any projects that you could help out with. I know a lot of people have done that. So like I said, students would come to us in the summer, they know they've got 3 months off, and they'd ask, is there anything that they could do? Not every lab offers that, but it kind of depends on the type of research that they do. So for example, our lab has quite a few short projects that don't require more than a few months worth of commitment, and we'd be happy to have people. You just need to approach a lab and ask them, and that's a very, very straightforward way to be involved in a project. Almost certainly, depending on your level of input, you could get a first author out of it. I think, I mean, I don't know of too many other ways you could sort of get publications that easily without sort of being involved in the research. I'm not somebody who does data type projects and that, data mining projects, but I know of colleagues that have very simple projects where they literally just give you a data dump and ask you to analyze it for them. That is another way, but I don't have the experience of that, I'm afraid.
Okay, so there's something along the lines that you might actually be able to help with, Pab. Someone's interested in anesthetics and ITU. Do you know anyone looking for a project, as every anaesthetist they've spoken to doesn't do academic work?
Yeah, there aren't many academic anaesthetists. That is a problem, which is what myself and my colleague are trying to change. So was the question, is that where do you find a academic?
Do you know any anaesthetist doing research, I guess?
I mean, there's me and my colleague.
Yeah, I was just going to say.
We've got the academic department at Imperial, the anesthesia, pain medicine, and intensive care. There's a good 15 of us. So if you go onto the Imperial website and into the Faculty of Medicine and Surgery and Cancer, and then look for APMIC, which is anesthesia, pain medicine, intensive care, all of those guys are intensivists and anaesthetists who all have their own lab doing research. So any one of them you could approach. They've all got, it says what their interest is and where their academic field of interest is, and you could select that and try and email them and see if they've got anything that you can do.
Yeah, perfect. And there's one question which
we do. So
I'll answer one of these questions as well. Are there any online resources or courses to help in research? For example, something that explains statistics. For statistics in particular, I would use the GraphPad Prism website, because they have excellent tutorials where they take you through a sample data set so you can see exactly what's going on and what to do. In terms of other resources, normally YouTube tends to have really good tutorials and courses. But if you keep a track of this series we're running, we're going to cover a lot of resources that will be helpful to people wanting to do research, including the statistics at some point. So stay tuned. And
can I just say one thing about stats as well? Yeah. You don't need to know as much stats as you might think. Every lab has its own type of data that it generates, and as a result, they can only do a certain type of stats to that data. So you'll find that if you do, for example, we do continuous data, and we can only do really 1, 2, or 3 way repeated measure ANOVAs with some t-tests. There is really nothing else we can do with that data because of the type of data that's generated. So you'll find that after a while, you become an expert in the stats that you need to know. So I wouldn't think about stats as an entire thing, because that's way too much. You'll find that you just narrow in on the stats that you need.
Yeah, excellent. I completely agree with what Pav said. You end up only using like 2 or 3 tests
Yeah,
at the end
I
of the day.
can't. I mean, I don't know any other stats. I only know repeated measure and over, literally. So,
And then we'll go to the last question just because we're pretty much out of time. How can someone get into research and med ed without a PhD or MD?
so the website that I mentioned, the three of those guys are non-PhD and MD researchers. They simply had an interest. I mean, they got into it as registrars and then continued it as consultants. They just simply kept doing projects. I mean, you don't need a PhD to do a research project. What you need is the appropriate ethics, an appropriate protocol, and some money to do it. So provided you can get those, you don't need a PhD. And these guys basically have got their track record and their lab purely because they just kept doing it. So I think the way to do research is to just sort of almost do it, if that makes sense. So,
I think there's been one last question. Pav, do you have a second more to
yeah.
answer this last one? I think it should be a quick one. Are there any research opportunities for junior doctors in the NHS?
Yeah. So again, you need to approach someone who's doing research and ask them if you can help out. And there's loads of projects, and often when somebody presents you with an audit or a QI project, it's very easy to tweak that into research as well. So always think to yourself, can I answer anything new? Whenever you do an audit, you're always obviously looking at comparing it to a standard, but can you push that into something new? Can you get new data out of it? As soon as you do that, you flip it into research, and it's very easy to get that published in BMJ Open, BMJ Innovations. It's surprisingly easy to tweak a QI project into research.
Great. Thank you so much, Pav, for doing this and for giving a super insightful
Yeah.
talk, which I'm sure helped everyone. Uh,
No
yeah, and I
worries.
hope to see everyone next time at the next webinar. Thanks again, Pav. We'll
Great.
uh,
Thanks
yeah,
for having me.
thanks
Cheers.
everyone. See ya. Bye, guys.
Bye.